faces. Megan just gave a wonderful review of adaptive radiotherapy and the application of velocity with workflows. So I will give you more detailed study using velocity to hopefully push the offline adaptive radiotherapy to reality. I have no disclosures. This project is led by Megan and participated by former residents April Smith and current resident Sarah and our dosimetry student Hervey. So the outline, first I will introduce motivation and clinical background, why we use deformable image registration, and I will give you a few literature review, the progress and comparison of different deformable image registration softwares, and I will introduce you our clinical study using prostate therapy. And the last part is a conclusion and discussions. So according to...
Sorry to interrupt, wait. So over here, we seem to be viewing your presenter view. So if you switch your two monitors, if you have dual monitors, then we can just see the slides. But don't worry if it's not easy to switch.
I'm not sure how to...
Up top in the display settings, I think.
Okay, this one, I guess.
Perfect now.
Is this one? Did you?
It was right.
Oh, it was right. This one?
No, it was right. Now it's wrong.
This one?
Yes, that's
yes.
correct.
Okay. So according to TG132, there are three major types of image registration. Rigid registration, which has only 6 degrees of freedom, 3 lateral transformation, and 3 rotational, which keep your relative distance between random 2 points unchanged. In addition to that, you have a fine registration, which is the rigid registration plus scaling and shearing and reflection. And then you have a deformable registration, which means each voxel in your image can be moving in 3 directions. So you have 3 times of n degree of freedom. So to evaluate registration, you have 9 criteria, which is listed below. So today we are just focusing on a few most important criteria. So application of DRR, including register like MR, PET to planning cities, segmentations, IGRT, which may not need a deformable image registration. Here today, we are just focused on adaptive radiotherapy in the case of patient lost weight, tumor shrink, and for prostate, specifically the bladder size change from day to day. And also we can use deformable image registration to evaluate the dose and outcome of the radiotherapy. So for velocity, as we mentioned, we can use adaptive radiotherapy to evaluate the dose change caused by bladder size change, tumor shrinkage, for head and neck, the chin position changes, and SRS may be caused by the mask rotation and the alignment issue. So hopefully after today's presentation, you have better understanding of how to use velocity to evaluate the prostate radiotherapy and hopefully we can improve the prostate radiotherapy by counter anatomy change and provide some guidelines, as Megan just mentioned, to guide therapists to monitor the bladder size before treatment. So DRR including three key components. One is objective function, which means you have to establish the criteria like SI, similarity index, or SSD square, sum of square difference, or correlation function, mutual information. In summary, you build up objective function to optimize the transformation from your moving target to moving study set to the target study set. And then you need a transformation model to help you make this transformation. So there are two major algorithms. One is B-splines, which is used for velocity. Another one is Demons algorithm, including the optical flow, fluid flow, finite element model, and biomechanical elastic model. So today I will just introduce B-splines and Demons algorithms. And of course, we have different methods to validate the algorithms, like evaluate the anatomy landmark change after the deformation, and we can use a physical model or digital phantom to evaluate the results. But this is not in the scope of today's presentation. So for Demons algorithm, it uses the Maxwell's Demon story. So basically, you have the structure to be deformed. Then on the membrane of the structure, you constructed objective function to decide whether this voxel is going out of the volume or transformed inside volume, and the magnitude and direction. So you can imagine that the shortcoming of this algorithm is it's required a lot of computing power and not very efficient. That's why in this study, they introduced extra active force to speed up the transformation. So I will just give you the results. The first panel shows the first CT contoured by physician, overlap with the second daily CT, and then you can see it's not a very good match. And then you perform the DRR, then the green line is the deformed contour. You can see it's successfully transferred the image. And the second panel shows the 4D CT in the expiration phase on 3 slices, which is contoured by physician and overlap with the inspiration CT, which is not a good fit. Then you perform the DRR, you transfer the contour successfully. So compared to Demons method, B-splines algorithm used in velocity just build the transformation function based on the combination of spline functions presented here. So you can choose either global deformation or local deformation, which just select limited control points to perform the transformation. So this method is more efficient and quick. That's the copied from the manual of velocity. That's the development timeline, the structure-based, structure-guided transformation, which was presented by Megan, is introduced in 2013. So this is another study, which also mentioned in Megan's slide, that This study compared 5 major commercially available DRR methods. So the green curve shows the deformation result of velocity. This is the displacement area in DRR histogram of the area in 2 directions. Another study shows the evaluate the DRR by compare the Hounsfield unit on each voxel before and after the deformation. So if the Hounsfield unit difference is bigger, which would be showing in blue and red. If the registration is successful, it should show the green color. So it lists the different algorithms and optimization methods used for different softwares. So here, when we use this technique to study prostates, we have 3 methods mentioned by Megan. We can use manual deformation and the navigator guided deformation, which is quite similar. So it requires you firstly match the 2 images with rigid registration. Then you select the region of interest to perform deformation. After the deformation is finished, you can evaluate it by either looking at the deformation vector field or by the Jacobian determinant map, which I will show you in the next slide. And then you update the object function, and then if you are satisfied with the deformation, you can generate the adaptive CT, which can be sent back to Eclipse and recalculate the dose. And after that, you can either evaluate the dose in Eclipse, or if you have multi calculations, you can send it back to Velocity and register to the planning CT and evaluate. And for the difficult cases, such as the bladder size change too much, or there is a contrast, or the soft tissue contrast in the image is not good enough. So you have to manually contour the structure in CBCT and then perform the structure-based deformation. And the rest of it is similar. So as I mentioned, to evaluate the DRR, you can look at the deformation vector field, which is shows here, how each voxel is going to be transformed. And Jacobian determinant map, which is showed in the color map. So basically you calculate the original volume and the transfer and deformed volume. On each voxel, you can calculate if the volume is going to be expanded or shrinked or unchanged. Then you can give each voxel a Jacobian determinants. If it's larger than 1, it means expansion. If it's between 0 and 1, the volume is shrink. And for non-physical motion, it gives you a negative value. And besides that, you can use the point of view. It's like a spot check. For example, here in the planning CT, you can select 1 point on the anterior part of the bladder. And then after transformation, you can just see if the transformed point makes sense or not. So in summary, we analyzed 51 patients, including 92 Cobin CTs to analyze. And we categorize categorize the plans by fractionation and also by the anatomy type. And then we evaluate those metric results by V65 for bladder and V70 for rectum. So first we can, since we acquired the weekly full field view CBCT for bladder for prostate patients, so we select those weekly CBCTs, perform the registration, generate the adaptive CTs, and calculate the dose, and then send back to Velocity to sum it up to compare to the planning CT. For example, this patient has 180 times 25, treated in 5 weeks. So each week we pick one full field review CBCT and then perform the DIR. So this is planning CT. This is the CBCT after we perform the transformation, deformation. Then you can see it matches very well. That indicates the deformation is successful. Another hint of the deformation is successful is we look at the blood volume in CBCT and compare with the blood volume in the generated adaptive CT, which is the volume of the original CBCT doesn't show here, but is very close to the reconstructed adaptive CT. That also indicates the deformation is successful. So we compare to the original bladder volume. So that's the bladder volume change in each CBCT. Then we just assume this represents the typical blood volume during this week. Then after we recalculate the new dose distribution, we give each dose weight 1/5 and add them up. Then compare to the original CBCT. The solid line is the original planning, and the dotted line is the recalculate dose distribution based on CBCT for this patient. So you can see this is very time consuming. So for many other cases, we just select a few CBCT to evaluate the dose according to the daily CBCT. So this is on the left side is a planning CT. On the right side is the CBCT after deformation. So you can see the deformation is good, even though the volume change is kind of big. The volume shrink by more than 30%. So this is another case. It's difficult, so we use the structure-based. We contour the bladder in CBCT, perform the registration. Then you can see the deformation of the structure in CBCT matches with the original planning CT very well. This is another case. The patient has contrast. We override the answer unit for contrast. We use the structure-based again. You can see compared to the planning CT, after we perform the DIR on the CBCT, it matches with the planning CT very well. Even though the original planning CT has a weird shape, we think it's acceptable. But this is the unsuccessful transformation. The main reason is the volume change of bladder volume is too big. It's 74%. That's the reason why it's not successful. Another one is the volume increase, the bladder volume increase compared to the planning CT. Because of the good soft tissue contrast, the deformation is still successful. Megan already showed this result, so I will just jump to the discussion. DIR has some limitations. So if there is contrast, if the soft tissue contrast is poor, it's not going to be very successful. And the structure-based DIR can improve the deformation. This is some extreme examples for very large bladder volume and regular ones. So conclusion. So based on the statistics, we recommend that control the bladder volume change within this threshold within either plus minus 50%, especially for volume increase, we try to control it within 10%. So thank you.